Hi everyone, thank you for joining us today. Today's tutorial is on obstructive lung diseases given by Dr. Wang. Just a few rules. For those of you watching via Zoom, questions and comments for things that are covered in the moment during the tutorial, just pop into the chat, and questions that can wait till the end, just pop into the Q&A. If you're watching on the Facebook live stream, just comment your questions or comments and we'll pass them on to the tutor and he will address it when appropriate. Otherwise, that's all from us, and I'll hand over to Dr. Wang now. Thank you.
Right, hello guys. So, hi, my name is Dr. Poh Wang. Yeah, graduated Imperial 2018, currently F2, and did a respiratory BSc. So I'm going to walk you guys through a bit about some obstructive lung diseases, a bit about respiratory failure, a bit about asthma and COPD, a few questions checked in. Yeah, if you've got any questions, just pop them in the chat. Okay, so standard disclaimer. Representative view of any of the original creators. This is just to teach you guys. Don't take anything for golden, as it were. We're going to move on. So some learning objectives. I'm going to give you a bit of an outline of some obstructive versus some restrictive lung diseases. Earlier on, we'll go through a bit of respiratory failure, type 1 versus type 2, the differences in terms of assessing it, in terms of management, in terms of what the diseases are. We'll go through a little bit about ABCDEs and a bit of how you can structure your investigations in a coherent manner. And we'll talk a little bit about asthma, pathophysiology, community management, acute management, and likewise for COPD, about the acute and in terms of some of the long-term management. Okay. So we're going to talk a little bit about some obstructive versus restrictive lung diseases. So first of all, in terms of lung diseases, all of these diseases that we have here, in terms of obstructive or restrictive lung diseases, present somewhat clinically similarly in that you're going to get people with shortness of breath, in terms of chronic shortness of breath, in terms of lots of exacerbating factors, and they're also going to get some episodes of acute shortness of breath. Now, the diseases are classified into obstructive, restrictive lung diseases, mainly due to their pathophysiology. And the way that I found easiest to think about this was that obstructive diseases were diseases with flow problems that, in terms of your windpipe, in terms of your trachea, your bronchioles, there was a flow problem in, flow problem out, and that's obstructing your ability to blow air in and to inspire in air as well. But whereas with restrictive lung diseases, it was a size problem, that the size of your lungs was restricted, that there's some fundamental structural abnormality of your lung tissue which prevents your lungs from expanding as normal to that appropriate size. So what this is going to be relevant for you for is effectively, this is going to be, you're going to see a lot of diagrams in terms of flow volume loops. That's going to be relevant in some of your exams, and it's going to be relevant in terms of some of the management that we have for this. So first of all, we'll talk through about some of your exam stuff. So on the right, we've got some diagrams, some common flow volume loops. So this is what you'll see on ventilatory machines. This is what you'll see on spirometry when people test and try and diagnose these obstructive and restrictive lung diseases. So what we have in a flow volume loop is y-axis is flow, x-axis is volume. So basically, what you're measuring in terms of this is some expiratory flow in terms of how fast you can blow air out. Basically, this upwards part is how fast you can blow air out. So what we see initially is that you can blow air out really, really quick up until you hit your peak, and then it just slowly goes down in terms of how fast you're expiring air. And in terms of breathing in air, yeah, you can take a fairly large scoop and it's fairly constant throughout. You don't really get that sudden peak, and it's a lot more gradual area. And that's what a normal lung looks like. And generally it takes about 6 to 10 seconds in terms of how much time it takes to completely empty your lungs in terms of blowing all your air out. Now, the differences that you can see in terms of obstructive and restrictive lung diseases. So our green box is our normal lung function in terms of flow volume loops, and the gray lines are the obstructive lung diseases. What you can see is what they have here is FEV1 over FVC, which is less than 70%. And what this means is your FEV1, that is how much air you can blow out in 1 second at maximal expiratory capacity. It's a very good indicator of how obstructed your airways are. And if it's less than 70%, you're felt to have, well, you are, by the criteria, you have some degree of lung obstruction. So what you can see on the graph, because FEV1, that's the y-axis, FVC, which is your volume, is the x-axis. What that effectively gives you is the gradient of the graph that you can have. So effectively, the gradient of this graph is going to be less sharp. It's going to be less slanted than a normal lung in terms of the green line that you get, because you're simply not able to push out air as quickly as a healthy lung. And you can see that the amount of air that you can push out and the speed of air that you can push out is significantly impaired compared to a normal lung. However, it doesn't really affect the volume that you can inspire in, because you're doing that slowly. You've still got good lung elasticity. You haven't got that problem in terms of your lung elastic, in terms of sucking air in. That's normal. Whereas restrictive, what you can see is that that flow volume loop is a lot smaller compared to the obstructive one. And it's got a qualitatively different pattern as well, that it's just a lot smaller throughout, that your lungs, they don't have the elasticity to expand to a sufficient size, and they don't have the elasticity to contract, to push the air out in terms of sufficient size as well. So we're gonna have a look at a few of the potential causes of this. So causes, the classical obstructive lung diseases are asthma and COPD. So asthma causes some form of autoimmune obstruction in terms of buildup of tissue, in terms of IgE, which causes your lungs to not be as patent, or your airways to not be as patent as they are in normal lung tissue. And COPD causes it similarly, but that's mediated by the damage that the smoke causes you. Whereas in restrictive lung diseases, you have interstitial lung diseases, idiopathic pulmonary fibrosis. There's issues with the lung elasticity itself, obesity, pregnancy, where you've got difficulty in terms of the size or the weight that you've got pressing down on your chest cavity, or your abdomen, your womb is getting larger. And likewise, in severe COPD, you can get air trapping, that your lungs get so hyperinflated you can't inspire as much, and they restrict the size, as well as any sort of paralysis and lung weakness. But effectively, what you're going to get in terms of some exam questions is you're going to get that the spreadsheetable differences that you get is that FEV1 in obstructive lung diseases is going to be massively, well, significantly reduced compared to restrictive lung diseases, where it's a bit reduced. The FVC is only going to be slightly reduced, which is your forced vital capacity, which is your total lung capacity, your lung capacity, your effective lung capacity, and compared to it being significantly reduced in restrictive lung diseases. Your FEV1 is going to be significantly reduced in your obstructive lung diseases, the amount of air that you can expire in 1 second, whereas in restrictive lung diseases, it's going to be normal or nominally increased. And your FEV1 over FVC is going to be particularly low in your obstructive lung diseases, which is the speed at which you can expire that air, which makes sense because you've got a flow problem in, flow problem out. Whereas restrictive lung diseases, it's normal. You've got a normal flow, you've just got tiny lungs. So yeah, that's normal there. And in terms of some of the diseases for obstructive lung diseases, you've got asthma, you've got your bronchiectasis in terms of having mucus present in terms of the airways, obstructs the size of it, obstructs the amount that you can suck in and blow out. Bronchiolitis obliterans, likewise for damage to the tissue, scar tissue, restricts the amount you can suck in and suck out. And likewise with COPD. And sarcoidosis, pulmonary fibrosis, asbestosis, all involve some kind of scarring, immune deposition of some non-elastic fibers, which reduce the elasticity of your lungs, how much they can expand, how much they can contract. And likewise for ARDS, respiratory distress syndromes, that affects the elasticity of your lungs in terms of the total size that they can go for. Hyperscoliosis, musculoskeletal disorders, that is just purely mechanically that your lungs, they don't have the muscles to expand. Hyperscoliosis, your spine is going to be bent over, you're going to be cramped over to your side, your lungs aren't going to have the capacity to expand, and neuromuscular disorders as well. Okay, so we'll go through a few questions. So in severe COPD with a restrictive component, will spirometry show a typical restrictive pattern, or will be a mixture of both restrictive and obstructive? Both. That you can have the initial obstructive picture, and then basically that obstructive picture, it all shrinks down, that it all gets smaller. So it's like an obstructive shaped but restrictive sized spirometry pattern. And how does air trapping in COPD cause restrictive lung disease? So effectively, with COPD, your lung elasticity gets so bad that it's like breathing in, trying to breathe whilst you're already at your 80% of lung capacity. That imagine if you're sucking in air and you're breathing and you've just sucked in as much air as possible, and that you can only take tiny breaths, just ventilating about 10-20% of your lung capacity compared to the 100% all the way in, all the way out. Like, you can try for yourself. You just breathe in all the way to max capacity, only let a little bit of air out, let a little bit of air in, and that's effectively, symptomatically, what patients with COPD feel, that their lung capacity, their elasticity is so shot, it's so poor due to the damage that they have, that their lungs, they've got loads of air in, but the air is trapped because it can't move in and out. So that's the way how COPD causes restrictive lung disease. Okay. All right, type 1, type 2 respiratory failure. Fine, so we're going to talk about respiratory failure is effectively a failure of gas exchange in some capacity. Now, gas exchange in the lungs is dependent on oxygen coming in, CO2 coming out. And basically, it's dependent on two factors. It's blood in terms of perfusing around your lungs, your pulmonary arteries, and it comes very close in your bronchi, your bronchioles, your alveoli, to close proximity to air, where oxygen comes in and the CO2 comes out via diffusion. Now, there are two types of respiratory failure. Number one is hypoxaemic type 1 respiratory failure, which is about your low oxygen levels. And this is a very important number. These two numbers are absolutely critical numbers. You must know these off by heart. I will fully say that throughout medical school, throughout your career. So basically, low oxygen levels are an ABG with a PO2 of less than 8. That is, if it's lower than 8 on the ABG, this person is hypoxic. No questions about that. Hypercapnic respiratory failure. is type 2 respiratory failure, which is low oxygen levels. So you've got your oxygen levels less than 8, but you've also got high CO2 levels, i.e. the ABG CO2 is greater than 6. So once again, low oxygen, hypoxic is oxygen less than 8. Hypercapnic is CO2 greater than 6. Two big important numbers, absolutely critical for whatever you're going to be doing. So hypoxaemic respiratory failure can be caused by a variety of things. So one is ventilation and perfusion mismatch. The air isn't going to the same bits as the blood, and this can be caused by pneumonia, that you're getting some mucus production, you're getting lots of infective, goopy sputum, which isn't allowing air to penetrate the alveoli and get to the blood. You can have it in pulmonary embolism, which is pretty much the opposite, that, yeah, the lungs are fine, but the vasculature, the pulmonary arteries have got a great big clot in them, which is preventing blood from going through that section. And for that section of lung, which is occluded and embolized, there's no blood going through, and it's just not working. Asthma can cause this because it stops the ventilation. That if you've got really obstructed airways, your air can't go down, can't come back up again, and you're not getting enough of it. And pulmonary edema, fluid on the lung, similar mechanism to pneumonia in terms of having extra fluid, basically. It's just a greater diffusion distance for the air to diffuse with the alveoli. Now there's shunting, where you can get blood moving from pulmonary to systemic circulation. Blood can bypass the lungs. So if you've got particularly severe asthma, particularly severe pneumonias, particularly severe respiratory distress syndromes, you can note that blood can move to different parts of the lung in terms of places where they're not used properly and where they're particularly infected. And in terms of hypercapnia as well. So this, you'll mainly see in intubated patients that the oxygen and CO2 levels, it's mainly people who are on rebreathers or some kind of mechanical ventilation, that they can be re-inspiring their own CO2, which is bad. You don't get enough oxygen for that. And likewise, for high altitude, if you're just way up in the air, lower FiO2, fraction of inspired oxygen in the atmosphere, you're going to get less oxygen in your bloodstream. But the main management of type 1 respiratory failure, the hypoxemic, so give more oxygen. Give them high flow oxygen, as much as you need to put them above 95% in terms of their oxygen sats. But you've got to be careful that they're not in type 2 respiratory failure, because a lot of these type 2 patients, they depend on their hypoxic drive. Normally humans depend on our hypercapnic drive. It's if our CO2 levels go up, we get this mammalian response to gasp, to get more air in and out. But there's certain type 2 hypoxic patients, type 2 respiratory failure patients, who lose that drive. So if you give too high in oxygen, they can have trouble in terms of their respiratory drive. As well as you can have CPAP. So CPAP is basically slow up, pushing air into your face. You put on a mask, it's hooked up to a CPAP machine, and all that does is pump a steady stream of air in your face, down your mouth, down your throat, to open up the alveoli. So it's effectively just putting a fan in your face or sticking your head out of a car window, and it just opens up your airways, gives you a bit more oxygen. And you have to treat the underlying cause. So basically, if they've got a pneumonia, you treat the infection, or you break the clot in a PE. So hypercapnic respiratory failure. This is mainly an issue with ventilation. So this is a ventilatory issue, that the patients, they have decreased total ventilation, i.e. their respiratory rate is poor, or they've got increased dead space in their lungs, whether it's COPD, whether it's opiates. So COPD, I've told you about the air trapping. You've got air in your lungs, but it isn't moved. So it's basically dead air, dead space, useless, hasn't moved in or out, and it's not ventilating. Opiates, that's going to impair your respiratory drive and respiratory exhaustion. When people get really, really tired in terms of asthma, they literally can't breathe in or out because they're just so knackered. You can get some increased inspiration of CO2. It's only really an issue with intubated patients rebreathing their own CO2 when they're getting ventilated there. So the the management of this is basically fix their ventilation if they've got type 2 hypercapnic respiratory failure. So you do this, number one, by increasing their natural ventilatory drive. So reverse the opiates, give a bit of naloxone, give some oxygen, encouraging them to breathe in or out. In terms of COPD, what you can do is you have to give them a certain degree of oxygen in terms of, you don't want people to be hypoxic, but you want to titrate that so they've got an oxygen level of approximately 88 to 92%, because at least then they will have some respiratory drive. You're not going to completely wipe it out, their respiratory drive. You can treat it with some salbutamol, some ipratropium as well, and you can ventilate this person. So if they can't ventilate by themselves or it's insufficient, you can do two types. You can have either invasive ventilation, where you're intubating people, you're giving some kind of inspiratory positive airway pressure, expiratory positive airway pressure, and basically breathing for them, just breathing in and out with a tube down their throat. Or you can do non-invasive ventilation, which is putting a mask on their face, and this machine just blows air in, blows air out. So it shunts air in, shunting their airways open, and it just effectively sucks air out, which breathes for them. It's kind of similar to intubation, but the fact is you don't need to actually stick a tube down someone's throat. And this is critical in COPD. So we'll talk a bit about that later. So yeah, this is basically a big spreadsheet, useful for exams, useful for various other things in terms of various criteria. So there's hypoxic, type 1 respiratory failure, your oxygen's less than 8, but you've got a normal CO2, and type 2 respiratory failure, where your CO2 is greater than 6, and you're hypoxic as well, so your oxygen's less than 8. We've got some categories of them. So you've basically got your pneumonias, pulmonary edemas, pulmonary embolisms, pneumothoraxes, and asthma, which cause type 1 failure. And then you've got your type 2 respiratory failures, which all of these are basically issues of, all of them are issues of oxygenation. All of these things, you don't get enough oxygen. That's why you're short of breath. But type 2, you've got ventilatory problems. You literally can't breathe in or out. Here, yeah, you can breathe in or out, but it's obstructed some way in terms of the oxygenation distance. Here, you might also have the oxygenation problem, but you've also got that ventilatory problem. And all of these cause similar problems in terms of symptoms. So you've got shortness of breath, mainly like agitation in terms of type 1 respiratory failure. But you get a bit of drowsiness, confusion coming along in terms of people who've got quite severe type 2 respiratory failure as well. And now I'm going to talk about my investigations a little bit later, but what is important is that you have a structure. This is a pretty decent structure in terms of what examinations you're going to be doing at each point, and it's a pretty decent overview of what you're going to have to do in terms of any sort of respiratory viva that you go through, and it's just laid out in a map. I'll revisit it later, and in terms of some other management. So you oxygenate in terms of oxygenation problems, aiming oxygen saturations greater than 95%, and then you treat whatever underlying cause that you've got. Whereas in terms of type 2 respiratory failure, you're aiming in terms of certain diseases like COPD at 88 to 92%, and then you're treating the underlying cause, and you can treat that with ventilation as well, so non-invasive or intubation. So we're going to talk a little bit about this. So we've got a question. So you're asked to review a 63-year-old female who's admitted with shortness of breath. On your arrival, the patient appears drowsy, around 10 liters of oxygen via a mask. You perform an ABG, which reveals the following results. So that PO2 is 7, pH is 7.39, PCO2 is 9.1, hydric carbonate is 26, and then base excess is +1. So are they in type 1 or type 2 respiratory failure? I'll put a poll up. I'll give you guys a little bit more time, maybe about 20 seconds to get through. Yeah, so pretty definitive. Yeah, they're in type 2 respiratory failure. First of all, they're hypoxic because their O2 is less than 8, but also their PCO2 is greater than 6. So yeah, type 2 respiratory failure. You've got to keep an eye on this lady. She is retaining CO2, which is a particularly bad sign. Okay. So same lady. Now, can you give an idea of what is her give an idea of what she has? Okay, so I've launched the question, what does she have? Basic SBA, what kind of problem does she have? Is it respiratory acidosis, metabolic acidosis, respiratory alkalosis, metabolic alkalosis? Give you guys another 10 seconds or so. Yeah, so we've got our answer. This is a bog standard respiratory acidosis. I'll tell you guys why. So you can tell it's an acidosis because her pH is acidotic. It's less than 7.35. Now, the question is, so it's either A or it's either B. Now, whether it's respiratory or a metabolic one, you can figure this out by looking at the CO2. What is the CO2 doing? So what is driving this acidosis? Is it the CO2? Is it the carbonate levels? So what you can see is that the CO2 is raised. Now, with the CO2 being raised, there's a buffering system in the body, which is going to be converting this excess CO2 to carbonic acid. And that is basically what's causing this respiratory acidosis. And what can confirm that is that you look at the hydrogen carbonate, that's normal. That if this was a metabolic acidosis, you'd have a lot less hydrogen carbonate because that would get burnt up, that would be used up to neutralize these excess hydrogen ions, which is causing this. But yeah, respiratory acidosis, ladies and gents. So I'm going to walk through really quickly about some ABCDE assessment and some of the investigations that I went through before. So I'm sure all you guys know a bit about ABCDE, but we're going to go through it really quickly. So initially, you have a look at the patient, you do your doctor, ABC, any danger, any response. If you're worried, shout for help. You're going to be looking at the airway. Now, with respiratory patients, is this airway patent? Are they talking to you? Are they having problems talking? Are they choking themselves up? Are they gurgling? Are they completely obstructed where there isn't any sort of airway, which is an emergency, and you need to put out a crash call there? So in terms of their breathing, so you're going to be looking for your observations. What's their oxygen sats? What's their respiratory rate? You're going to be looking at them, seeing their color, if they're warm, sweaty, pink, if they're cold, blue, cyanosed, if they appear short of breath, if they're using any sort of accessory muscles, as well as your obs that are present there. You're going to be listening as well, so you're going to be auscultating, seeing if there's good air entry bilaterally, any zones there isn't good air entry, any sort of crackles, any sort of crepitations. You're going to be percussing, seeing if they've got any sort of resonance, any dullness that's present there, seeing if they're particularly coughing, what does that sound like, seeing if they've got any wheeze, or if they've, worst of all, got any sort of silent chest. And you can also going to be having a feel, see, like, have a look at their trachea, see if it's deviated, see if they've got any sort of pneumothorax, see if they've got any equal chest expansion either side. So you're going to be looking at their circulation next. So standard obs, blood pressure, heart rate, cap refill, what's their temperature. You're going to be seeing if they're cold and clammy, seeing their peripheral, central pulses and their refill times, seeing if there's any sort of bleeding present, any sort of heart sounds, whatever. Look for murmurs, see if there's any difficulty there. And once again, disability. So check their glucose, check their GCS. Are they acutely confused? Are they tiring? Confusion is an acute sign of people tiring, and it's a very bad sign in terms of your respiratory assessment. And once again, look at everything else. Expose your body, expose your patient. Have a look at their chest, see if there's any signs. Look at their legs, any swelling, any sort of DVTs, and any broken bones, whatever equivalent. So this is what I like to do. So in that point, you'll stabilize your patient, and effectively you're going to be giving them some oxygen, and that's what you do in respiratory scenarios. And now the question is, you might have given some immediate management in terms of salbutamol, in terms of nebulizers, in terms of inhalers, but now you've got to come up to a definitive diagnosis, and you've got to order some investigations. And if you've been listening to Amir Sam in anything over the past 6 years, he will have told you something called BB fish in a way of structuring your investigations. And this is important because you have to do it in a coherent manner, both for your sake when you're actually practicing on the ward so you don't miss stuff, and for your exams, because otherwise you're going to become incoherent in your vivas. So BB fish was the way that I always did it, was that you start off with your bedside investigations, you get your observations, you do your ABCD, you do your resp exam, you do your peak flow, your ECG, all this stuff you can do at the bedside. You take your basic bloods, so your full blood count, your U's and E's, your CRP, your bone profile, liver functions, whatever else you need to do. You can take cultures if they're pyrexial. And with respiratory patients, people who are sick, you need to get that ABG. This is critical. It's going to determine your management. It's going to give you a prognostic indicator. It's going to tell you if they're in type 1, type 2, and they'll see how. So the things you can do. Fluids, so get your sputum cultures, get your viral swabs, get your urine dip and antigens, your various pneumococcal urine antigen tests, get your imaging. So it's going to be a chest x-ray. You do a chest x-ray for pretty much every sort of respiratory patient. Asthma, COPD, pneumonia, PEs. No radiologist is going to allow you, want you to do a CTPA without some kind of preceding chest x-ray. And then you can move on to some of your special tests, such as spirometry, and then you can get some histological diagnoses, bronchoalveolar lavage, biopsies, but that's not really that acute. So we're going to move on now a bit about asthma. So the slides are going to go around, but it's really important to structure your investigations. So we're going to talk a little bit about asthma now. So asthma, it's a common chronic disease, and the main characteristic factor is reversible expiratory airflow limitation. So it's an impairment in how much you can breathe out, how fast you can breathe out in terms of your FEV1, how much your lungs can breathe out in the first 1 second of inspiration. But you can reverse this, and you can reverse this with a lot of common drugs, and it generally is pretty responsive to being reversed. People also get some cough, they get some shortness of breath, you get some wheeze, you can get some chest tightness, and especially at night if people have some exercise as well. So people, asthma is one of the triad of diseases of atopic responses, basically. So eczema, asthma, hay fever, allergies, all these are IgE mediated, and they all have similar epidemiological linked criteria. Now, you'll get some diurnal variation in your symptoms, which is, it'll be worse in the morning. Generally, a bit better at, it can be worse in the morning, it can be worse at night, and it just varies through the day. This can be related due to some circumstances in terms of air, in terms of pollution, in terms of pollen, but it can also be related to the amount of cortisol that you have in your system. Now, in terms of asthma, your examination can be normal. You might hear a wheeze, which is very indicative of that, but you might find that this person is just symptomatic, and you can't find any sort of impairment to their oxygen levels, and you can't find anything on examination. But they are just feeling very short of breath and very wheezy. And this is very common. This is bog standard, basically. So this causes a fair amount of deaths per year, about 2,000, and this is getting more and more common because we're all living in a cleaner environment, that we are getting more atopic because we don't have pets at home, we don't see animals, we don't go outside, people are cleaning everything, and we're not getting that early exposure to pathogens and sensitizers, which causes some atopy. Okay, so we got some questions. Do I run by imaging and special requests by your SHO first? Well, order a chest x-ray anytime. As an F1, literally just order that. It depends. Basically, when you're clerking people in, yeah, you should just be ordering these basic investigations. I would have a discussion with someone before you order a CT for them, because you're going to be irradiating them for some significant amount. But in terms of the amount of radiation that you can subject someone with a chest x-ray, it's in the degree of bananas. How many bananas are they going to have today? So it's something that is very bog standard, and you will be expected to order that anyways, as in by yourself, as an F1, but run the CTs by your SHR. And in terms of resources I mentioned when talking about BB fish, so basically, this is something that we got told at Imperial by one of our head of years, that this is the way that they want you to structure your investigations. Bedside, bloods, fluids, imaging, special, histology. You can apply this to pretty much any sort of particular subject, any sort of condition. Just have a think in terms of your cardiac exams, in terms of your respiratory exams, in terms of your neuro, in terms of your abdominal stuff. This is how you structure your investigations that you're going to order. Okay, so we're going to talk a little bit about this. So there's two types of asthma. So there's extrinsic, which is IgE mediated, which is the allergic asthma. Occurs often in childhood in response to your environmental irritants, often associated with A to P, so asthma, eczema, allergies. Often gets a bit easier during the teens, not as severe, but can recur later in life. And you've got your intrinsic, where you get a normal IgE level, and it's a non-allergic response. It's thought to be a bit of an autoimmune response where it can develop a bit later in life or post certain upper respiratory tract infections. It's more progressive, and it's generally a bit less responsive to treatment. So irritants for asthma can include bronchospasm, they can cause inflammation, and this is basically the mechanism of how it causes this obstructed lung picture. So you get a bit of bronchospasm, you get a bit of inflammation via this irritant coming into your lungs, getting in contact with your lung tissue. Now, this irritant causes some inflammation. This inflammation causes a bit of edema in that soft mucousy tissue that you have, causes some mucus secretion. If this happens long enough, it causes some smooth muscle hypertrophy in terms of your tissue, in terms of your airway tissue. And with this hypertrophy, if it occurs often enough, it can cause a bit of fibrosis, which is a permanent obstructive type picture in terms of your airways just getting smaller because there's muscle building up. So in terms of various stimuli, common things are house dust mites, pollen in the air, cat hairs, viral infections, cold air, cigarette smoke, any sort of exercise, any sort of emotional stress, which can cause this. And certain drugs are particularly contraindicated. So beta blockers, NSAIDs, they can cause some vasoconstriction themselves, and that can, and NSAIDs can impair the COX pathway, which can mediate some airway constriction. Okay, so basic community investigations that you go through. So this is one of the BTS guidelines of investigating asthma. And basically what you do in GP, in the community, is you give people a peak flow diary. You've got to see if they've got any sort of variation, daily variation in their peak flow. It'd be useful to see a diurnal variation, but don't depend on that in terms of diagnosing this. Some people have it, some people don't. But if there is an impairment in their peak flow and the FEV1 over FVC ratios for their age, for their height, then yeah, you're suspecting this if the history is giving them something similar. And reversibility is a biggie as well. If you give them an inhaler, bit of salbutamol, and they feel better after this, then that's a pretty big indicator that they've got asthma. So you do that first line response, give them that inhaler, give them that peak flow, give them a diary, give them some instructions. And then if you want to follow up a bit more, you can do a few lung function tests. So, and a few reversibility studies. So in this case, this is FeNO2, which is the fraction of expired nitric oxide. That nitric oxide can act as a vasodilator, and it helps in terms of people opening up their airways. And if that's particularly impaired, that can be an indicator that they have asthma, as well as spirometry. If they've got that classical, very sharp gradient and spiked peak in the flow volume loops on spirometry, that's a pretty good indicator they've got some asthma. And in terms of management, you got to treat this. So I will go through the management a little bit later, but first line, you give them that salbutamol inhaler, consider some steroids. You've got to educate them about symptoms, that they do need to take certain brown inhalers in terms of their corticosteroids every day, how they deal with deteriorations. If they have more than, say, 4 uses of that, 3 or 4 uses of that inhaler a week, and they might need to get stepped up in terms of their treatment, and you start going through the BTS therapeutic ladder. So this is the old BTS therapeutic ladder. This is what we were using 2012 all the way up until 2019. And basically, you start off mild intermittent asthma with some short-acting beta agonist, which is salbutamol. You give them your blue inhaler. And then you would add on your brown inhaler, which is budesonide, fluticasone, get them to do this every day, which is their preventer inhaler, stuff they use every day to prevent them from having to use the blue. You add on your LABAs, which is basically your salmeterol, formoterol, a longer acting version of the salbutamol. And then at this point, you can either increase your dose of corticosteroid, you can add on your montelukast, and if the LABA isn't working, you get rid of your LABA. And then if this isn't working, then basically specialized care and put them on a steroid tablet. So you can consider some omalizumab, which is one of those anti-IgE monoclonal antibodies, and oral steroids. But the oral steroids are a big deal, basically. You're very likely to cause Cushing's if you give someone some oral steroids for any particular long period of time. So they do try to limit the amount of time that they put people on this. But this was old. This all got changed in 2019 to something like this. Well, in fact, we directly got changed to this. So this is the 2019 pathway. And this is important. Just learn this, basically. Learn this. This is going to be in every single one of your exams with every single dosage of every single thing. This is one of the highest yield slides or diagrams that you'll get through med school. So basically, pretty similar to the previous one, except what you notice is they've moved the low dose ICS right to the front because they want to emphasize the importance of having a daily preventer for your asthma. So once again, salbutamol there throughout. It's your reliever therapy. If you're short of breath, you have that. But start off, have a very low threshold to start people on budesonide, fluticasone on their brown inhalers alongside salbutamol. It's basically they're saying do this ASAP, and then yeah, you keep them on that budesonide, fluticasone. You can add on your LABA on top of the salbutamol, on top of your ICS. You've got your LABAs, salmeterol, formoterol. Once again, you increase the dose. You can see if they respond to montelukast, and you can reduce the LABA if that's not working. And once again, specialist care. So your monoclonal antibodies, your steroids. But all this effectively is different from the old one, is that it's moving the budesonide alongside the salbutamol. So instead of just salbutamol alone, salbutamol, budesonide, the rest is pretty much the same. Okay, so yeah, here's a list of various LABAs, LAMAs, ICS, things that you can take. And it's similar for COPD. So we're going to talk a bit about acute asthma management now. So we're going to go through this and picture a patient in front of you who's having a really bad asthma attack. So they're going to be short of breath, they're going to be a bit agitated, a bit panicky, might be a bit confused, heart beating quickly, they might even be getting a little bit blue, and they'll be wheezy. You might hear something on examination, they might have some impaired oxygen saturations, and they're going to be acutely short of breath. When you do your ABG, you're going to have some reduced oxygen saturations, and if they're particularly bad, they might have some type 2 respiratory failure in terms of their CO2 climbing up. So various investigations that you'd want to do. So you do your respiratory exam, you do your OBS, you do your peak flow, which is impaired. You'll do some bloods. You want to see if this is an infective exacerbation. You might do some cultures likewise if you think that's an infective one. You've got your ABG, which is telling you if this is type 1, type 2, how bad it is. You can get a sputum culture, viral swab. You'll do that chest x-ray to make sure they don't have any sort of pneumothorax or acute pneumonia. And you're not really going to be doing your spirometry or your histology in that case. But now we're going to talk a bit about management. So you're going to be putting them on 100% non-rebreathe oxygen, 15 liters of oxygen, because if they're that sick, if they're particularly unwell in terms of their oxygen getting impaired, you're going to be wanting to aim to have their oxygen levels above 95%. And you're going to be wanting to treat the underlying cause, which is how we're going to go through here. So you put them on oxygen, and we've got a bit of an acronym. So the acronym so it's oxygen, put them in 15 liters, aim for above 95% oxygen saturations. You're going to give them some salbutamol, 5 mg of nebulizers, back to back, as much as they need. You're going to give some hydrocortisone or prednisolone, some kind of corticosteroid to try and reduce the inflammation that they have. But this isn't going to act acutely. Like, this acts in about 24 plus hours. This takes time to work. So hydrocortisone if they're unable to swallow, pred if they are able to swallow. You're going to give some ipratropium, which is some 500 micrograms nebulized. And at this point, if they're not responding, you need to seriously consider intubation. You as a junior are not going to intubate anybody. So effectively, this is contacting your ITU registrar, informing them about this, that you've got some patient with asthma that you're worried about, and they're going to have to review them. You can consider a bit of theophylline, IV infusion, 500 micrograms per hour, and start some magnesium sulfate, 1.2 to 2 grams IV. But overall, you're going to go, oh shit, basically. And when you get to the eyes, you really, really need to consider contacting ITU to see if this person's escalation up to for intubation. So, right, guys, I'm going to give you a bit of a question on some of our first-line drugs. So what are the first-line drugs for asthma on the BTS stepwise progression treatment pathway? So is it A, salbutamol and budesonide and fluticasone, B, salbutamol and salmeterol and formoterol, C, salbutamol and montelukast, or D, salbutamol and omalizumab, monoclonal antibodies, and oral steroids? So I've launched the poll. Give it a go, guys. So another 5 seconds. So 5, 4, 3, 2, 1. Yeah. So yeah, pretty definitive. It's your salbutamol and your inhaled corticosteroids, budesonide, fluticasone. Line 1. Line 2, you add on the third line and the fourth line. Okay, so we're going to talk a little bit about COPD now. So COPD is something else that is very, very common. You will see absolutely gobs of this, one of the most common obstructive lung diseases. So it is a chronic progressive respiratory disorder characterized by limited airflow limitation, which has limited reversibility. Whereas asthma responds relatively well to salbutamol, relatively well to ICS, corticosteroids, relatively manageable up until it doesn't, up until the severe cases. COPD, it's a slow progressive disease, which we have pretty poor treatment for, that it's a mainly supportive treatment, that we can't actively reverse this immune response because the damage is already done in terms of bronchiectasis, in terms of emphysema, in terms of structural, fundamental, permanent damage to the lung tissue. Whereas asthma, okay, they might have a temporary degree of inflammation, but you can reverse that with drugs. COPD, no. So this is super, super common. COPD kills 20,000 people per year in the UK. And the main risk factor, as you all know, is smoking. Smoking. There are some atmospheric pollutants. If you're around loads of exhausts for loads of the day, that can affect that, and as well as alpha-1 antitrypsin. That's another buzzword that you'll need to learn for your exams that can cause people to be genetically predisposed as well as having certain liver conditions. So another criteria for COPD is people having chronic productive cough for 3 months of each year for 2 consecutive years, or having abnormal permanent dilatation of their terminal air spaces. So the mechanism of how COPD occurs, so you've got smoking. Smoke, any sort of cigarette smoke, any sort of smoke, is full of really nasty stuff. You've got carcinogens, you've got free radicals, you've got irritants, you've got toxic products, cyanide, loads of crap. And all of this stuff, when you breathe it in, causes inflammation. And now this inflammation causes some mucus gland production. So mucus is going to get produced because your lungs are trying to defend themselves from all this toxic material that's on them. They're going to produce a bit of mucus, but if you're exposing them to this toxic material day in, day out, these mucus glands are going to get hypertrophy, and you're going to get far too much mucus production. And this mucus production is going to cause an obstructive effect, that it's going to block your airways, and it's going to prevent the air from diffusing across that membrane, across that barrier, because there's a greater diffusion distance to go through that mucus. This causes airflow limitation in your small airways. You're going to get destruction of your lung tissue, and you're going to get some dilatation of the air spaces which are distally because of all this destruction of your lung tissue and because of this excess inflammation and damage. Now, what you get in COPD is that your lungs lose their pliability, which is they lose their elasticity. And because they lose this elasticity and recoil, they, instead of being spongy like a balloon, they're like a really saggy balloon, which has just gained loads of extra space and can't squeeze it back out. So instead of being a balloon, it's more like a crisp packet or something. And basically, this causes dead space air trapping. So your lungs, instead of being compliant, spreading out and squeezing back in, they become permanently spread out, and they can barely squeeze in. And effectively, yeah, there might be loads of air in those lungs, but the air isn't able to come in and out. So effectively, it's dead space. 80% of your lung, 70% of your lung air just remains trapped in your lungs because you can't get it in or out, and it's just useless for your ventilation and useless for your breathing. So this is the dead airspace trapping mechanism, and this is what causes your hyperinflation. What you'll see in your chest x-ray, what you'll see clinically, people, huge barrel chests, puffing right at the extent of that expiratory capacity. Instead of going from 100 to, say, 20% in terms of their FVC, it goes from 100 to maybe 80%. So they've only got 20% of their lungs vital capacity to work. And you see them panting really hard. They have to increase the work of breathing. It causes their shortness of breath. So basically, as COPD progresses, the poorly ventilated lungs, they tend to accumulate CO2. So yeah, imagine your lungs are really, really full of air. Take a deep breath. You're at 100% of your inspiratory capacity, and you're just taking tiny, tiny breaths in and out. Right? Try it for yourself. What you're going to have to do to breathe is breathe very rapidly and breathe very shallowly. And what that's going to do is it's going to impair your ability to properly ventilate your lungs. You can't get all that air out, and so you can't get that CO2 out. You can't bring that CO2 in, and panting very rapidly at maximum capacity is going to make you tire very, very quickly. Your CO2 itself is going to increase. So to compensate the respiratory center in your brain, it becomes very tolerant to this high blood CO2. Whereas normal people, any sort of CO2 greater than 6, we actively think we're dying. We basically think that we have to take really deep breaths in or out. These people, they've been used to that. They've been used to that air hunger for so long that their brain has just gotten used to it, that they don't respond to that air hunger anymore. And they only respond to that O2, their hypoxic drive. So this is why for advanced COPD, if you remove that hypoxic drive, you give them too much oxygen, they can lose their ability to have any sort of respiratory drive. They stop breathing, and then you're in trouble. So yeah, the focus shifts the respiratory drive on their hypoxemia, and that causes that hypoxic drive. So basically, what you're going to get typically is some middle-aged person who smoked a whole ton. They've got some productive cough, which has been getting worse, either yellow, white, green, and they're short of breath. These symptoms have been getting worse over many, many years. Smoked an absolute ton. Beware of asthma in older adults, because it can come along as well, and you want to see the reversibility. So you're going to be wanting to peak flow instead of assuming, or COPD people instead of assuming that this middle-aged smoker has COPD, you might want to check if they have asthma, because you can actually reverse that and you definitely need to get a smoking history, any sort of respiratory patient. So these people, they're going to have some reduced exercise tolerance. They've got to get some wheeze whenever you're listening to their chest. On examination, you might find that they've got some hyperinflation, very large barrel chest. You might see this on the chest x-ray. They might have some coarse crackles if they've got any sort of acute exacerbation, any sort of infection. They might have a wheeze. They might have some reduced breath sounds because they're very hyperexpanded. They can barely get any air in or out. They'll be hyperexpanded, so you might get some hyperresonance whenever you percuss. They might have a very long expiration time because they just don't have the elastic recoil in their lungs to push the air out. They might have some pursed lip breathing, which is a mechanism to increase the peak expiratory end pressure. Because if you can't really get your air in and out, because you're so hyperexpanded and you've got so much air trapped in your lungs because there's such lack of elasticity, if you purse your lips at the peak whenever you're trying to breathe out, you can actually shunt open some of your alveoli, which can help open your lungs and reduce some of the air trapped present in there. And they might be grabbing their rail and they might be tripoding, which is a position where people, they lean forward and they take some deep breaths in and out, which is pretty much the most optimal position for them to open their lungs up. So spirometry, you can help confirm the disease. You can assess their severity. You can see this obstructive picture, which is their FEV1 over FVC of less than 70%. So that's the obstructive picture, which I showed you about. And if it's bad, it might get restrictive. So it's that obstructive shape with a restrictive size, much smaller. So you can have a look at that peak flow after you give them some nebs. See if there's any reversibility. Reversibility is more indicative of asthma. So this is a typical COPD chest x-ray. What you can see is it's super hyperinflated. You can see more than 6 anterior ribs. So 1, 2, 3, 4, 5, 6, 7, 8. So there's a lot of ribs. There's just a lot of ribs coming through in terms of this. You can get some hyperlucent lung fields. So you're not really going to be able to tell. I don't think you as an F1 or a final year will say, oh, these look like hyperlucent lung fields. It's just they've got very large lung fields and they've got a bit of a flattened hemidiaphragm where you can, well, it's just as a mechanism of their very expanded lungs. And what you want to do with COPD, because they've smoked for so long, you want to check out, see if they've got any coin lesions, see if they've got any sort of malignancy, and have a very low index of suspicion for that. So basically, long-term COPD management, we've got a list of some of our medications here, our LABAs, our LAMAs, our ICSs. The number one thing that you want to do for COPD, tell them to stop smoking. Really, just do everything they can to stop smoking, because this is going to prevent any worsening of this progressive condition, at least any acute worsening that they're actively causing every single day, and it can reduce their susceptibility to any sort of respiratory tract infections or any sort of exacerbations. There's similar treatments such as to asthma in terms of your short-acting beta agonists, which is your salbutamol. You can have your LABAs, which is your salmeterol and your formoterols, which have some mixed effectiveness. They can have an effect. It's a bit better than the salbutamols. You can have your LAMAs, which are the tiotropium, ipratropiums, which help with the muscles in terms of the elasticity of their lungs. You can give them some inhaled corticosteroids, which help reduce some of the inflammation which is present in their lungs, and some anticholinergics as well, which can similarly stimulate some reduced inflammation. These people, you'll need to get them up to speed with their flu jabs. With their pneumococcal vaccines, they are very susceptible to this. Some people can have some pulmonary rehabilitation, especially if they've got some recent exacerbations. Basically just learning how to take deep breaths in and out. You've got some respiratory physios who can help them with that. And that alone, like getting someone to take 10 deep breaths in and out every morning, lunch, evening, does make a difference. Now, certain complications they can get are respiratory failure, type 1, in terms of them getting hypoxic, type 2, in terms of getting hypercapnic. You get cor pulmonale, which is a heart failure which is due to respiratory failure. So the mechanism behind cor pulmonale is that when your lungs are shot, when your lungs are really, really crappy for any significant period of time, your body tries to remodel by shunting excess blood through those lungs. That it thinks, oh God, is this some kind of ventilation defect? And what this results in is a degree of pulmonary hypertension because you're shunting so much blood and you're getting your pulmonary arteries to remodel themselves and getting thicker and thicker and constricting more and more to shunt more blood through and cause that pulmonary hypertension. Now, that pulmonary hypertension, what part of the heart pumps to the what do you call it, to the pulmonary arteries? Like, give an answer. Like, I want someone to drop something in the Facebook, drop something in the Zoom. What part of the heart supplies the pulmonary arteries? Yeah, right ventricle, right ventricle. So it's right-sided for that. So your right ventricle ain't that strong compared to the massive hench left ventricle, which pushes blood all around your body, right to your head, right to your toes. Your right ventricle is only meant to push it a very small distance, very low pressures through your very delicate pulmonary arteries. And now, because your pulmonary arteries become very thick, very hypertrophied, and you've got pulmonary hypertension, your heart, your right ventricle can't keep up. So what that has to do, it has to undergo a degree of hypertrophy itself. So this hypertrophy is basically cor pulmonale, where your right ventricle gets very, very large, very hypertrophic, to push through a hypertrophic pulmonary artery due to the pulmonary hypertension from your crap lungs. And big right ventricles can cause big right sides of the heart can cause some bad stuff in terms of the blood, instead of going from left to right or right to left, it can get shunted the other way. And that's effectively what cor pulmonale is. So basically, other complications are pneumothorax. Your lung elasticity is going to be crap. Your lungs are pretty shot. The emphysematous, the structure is very poor. They're loose, they're floppy, they're not elastic. And say they can lose their elasticity and they can just lose their structure and just start to collapse, especially in COPD. And these patients can become polycythemic. So if you're very hypoxic for a long period of time, your body is going to try and remodel. Your body is going to try and compensate. And one of the mechanisms it does this by is your bone marrow producing excess red blood cells. So these people can be polycythemic, loads and loads of red blood cells, very high HB. That's a big sign of chronic long-term COPD. Now, what's really important with these patients is that you've got to discuss a ceiling of treatment sooner rather than later, because realistically, the COPD, it's not going to get better. You can't make this better. This is a progressive condition, which is going to get worse. And some of these people, they're not going to be for more invasive treatment. They're not going to be for ITU. And if someone's deteriorating very, very quickly and they've come into hospital, what you want to get very quickly on is some kind of escalation of treatment plan. Are they for ITU? Are they going to be sick enough for ITU? Are they going to be well enough for ITU? Do they have the exercise tolerance or the reserve physiological capacity? Or what do they want? Ultimately, if they're going to be bad enough, this COPD episode, that you don't think they're going to recover from being on a ventilator, you don't want to put them on a ventilator because they're just going to die on a ventilator. That's going to be horrendous for everyone involved. But for long-term COPD management, people who are severe, you definitely need to have that talk. And some people can have home oxygen. But this helps people symptomatically, also helps people in terms of their extension to their life duration, in terms of giving them a bit of oxygen. Being hypoxic for a long, long time really sucks. It's really unpleasant, but it also kills you as well because your organs are hypoxic. So we're going to talk a little bit now about some acute COPD management. So this is pretty similar to some of the asthma management that we have. We're going to run through this. So COPD exacerbations, they're, in terms of infective exacerbations, they're kind of like pneumonia, but you can't see anything on the chest x-ray. but they have symptoms, that they've got a chesty cough, they've got some kind of sputum coming up, they feel like they've got some kind of infection coming along. And it's kind of similar in terms of you treating it similarly to pneumonias, CAPs, HAPs, in terms of your antibiotics. But with COPD patients, because they've got these, they're very susceptible to infections, you generally treat them with something a bit different, which treats the atypicals a bit more than your bog standard amoxicillin. So generally, it's a bit of doxycycline for these people. So they can often have some worsening respiratory symptoms and some sputum coming along as well. So what you're going to do, someone with acute COPD exacerbation turns up. So you do your ABCDE, of course, you give them the oxygen that they need, you put them on some immediate nebulizer. Now you've got to think about what examinations or what investigations you want to do. So you've got your bedside investigations, you get your OBS, you do your resp exam, you do your peak flow, everyone gets an ECG, you do your standard bloods, full blood count, use and ease, your CRP, you'll take your cultures, if they're pyrexial, you may want to do an ABG. If they're particularly unwell, yeah, you'll want to do this. Certain people, you don't want to do this, or people, they don't want it. It depends. You want to get some fluids in terms of your sputum, in terms of your viral swabs. You might want to get some urine antigens if you think this is an infective cause. You want to get your imaging, which is going to be a chest x-ray. And generally, you're not going to go for your spirometry or your histology or your biopsy. But now, I'm going to talk a little bit about management for these guys. So it's a different acronym. It's OSHIA NIV. So the vast majority of this is similar to the oxygen or to the asthma pathway. But it's oxygen, salbutamol, your hydrocortisone or prednisolone, you've got your ipratropium, you've got your antibiotics, and then you've got your NIV or invasive ventilation if they're for that. So basically, you're going to give them some kind of oxygen, and you're going to be titrating this oxygen, whatever percentage, either a Venturi mask, either turning the knob from 1 to 8 liters. If they really need it, if they're really sick, you're going to be giving them 15 liters non-rebreathe. But you're aiming for an oxygen saturation with confirmed COPD, if they're a retainer, for 88 to 92%. You're going to be giving them some salbutamol, likewise with asthma, 5 milligrams, nebulized back to back. You're going to be giving them some hydrocortisone if they're not able to swallow, but generally these people are, in which case you'll give them prednisolone, about 14 days, 2 weeks of 30 milligrams of this. Give them a bit of ipratropium nebulizers as necessary. And if they've got an infective exacerbation, you'll be giving them some antibiotics. So everyone knows about amoxicillin for a HAP or for a CAP, and you can give them a bit of amox or doxycycline in terms of our general first-line ones for infectious exacerbations. Now, you get to the point where this person, if all of this stuff isn't working, they might need a bit of NIV. And this is something that COPD patients, they have very, very commonly. This is one of the bread and butter managements of people coming in with COPD exacerbations. So NIV, mask over their face, they'll be breathing some air in, breathing some air out for them, and effectively ventilating them because they can't do that themselves. Now, NIV, another name for this is BiPOP, PAP, and this, it's particularly useful for acidotic type 2 respiratory failure. Those acidotic CO2 retainers, when they have these type 2 respiratory failure, very hypercapnic exacerbations, which indicate that they're not keeping up with their ventilatory ability, that they can't ventilate effectively. And yeah, so we've got a question. Why is there no consolidation on chest x-ray? Is it because it's an acute infection? So if there's consolidation on chest x-ray, it's a pneumonia. Like pneumonia, one of the definitions of a pneumonia is that you have to have radiological changes. And basically, what do you treat a COPD person with pneumonia for? What do you treat them as? You treat them as a pneumonia plus a COPD exacerbation. It's basically some kind of, it's basically a definition issue in terms of this. If they've got some consolidation in the chest x-ray, this person has a pneumonia instead. But you'll still likewise be doing all of these things here in terms of the management for a COPD patient with an exacerbation and COPD patient with a pneumonia. It's just the pneumonia one. You can see it on the X-ray. So basically, let's have a look. So that's about it in terms of my presentation here. Got a few takeaway messages. Hopefully, I've walked you through some obstructive lung diseases, that they're a flow problem in and out, versus restrictive lung diseases, that's a size problem. Respiratory failure, type 1, which is oxygenation. Type 2, which is ventilation. In terms of oxygen, less than 8, they're hypoxic. CO2 greater than 6, they're hypercapnic. Basics of ABCDE assessment, having some kind of structure in terms of DB fish, and in terms of some of the basic pathophysiology and management of asthma, and likewise for COPD. So basically, guys, please do fill out a bit of feedback. Please give me a shout. If you do, I might do another one of these, another few of these in terms of hints for F1, useful clinical tips for final years, third years. Spread a bit of wisdom. It does help us in terms of our portfolios. But yeah, like, give loads of comments, what's good, what's bad, really does help. And yeah, we'll talk a bit more about this. And if people are happy to come on Zoom for like this one or the next one, I am happy to answer questions and talk about stuff just before I go on my night shift.